All right.
Alrighty.
All right. So we'll go ahead. Okay. Well, today I'm going to talk about supporting self-regulation for children with FASD. And this is Claire Coles from the Department of Psychiatry and Behavioral Sciences at the Emory University School of Medicine. I want to acknowledge that I have no conflicts of interest as regards this issue, but some of the research that we talk about has been supported by the Centers for Disease Control and Prevention and by the National Institute on Alcohol Abuse and Alcoholism. And I also want to thank a number of people within the laboratory here who have supported our work, including Sharon Page Whitaker and the staff of the Center for Maternal Substance Abuse and Child Development. As many of you know, there are a number of potential effects of alcohol use in pregnancy. And the umbrella term for all of these things are fetal alcohol spectrum disorders. They may involve growth retardation, either at birth or later, global cognitive deficits, but there also may be specific neurodevelopmental impact, even in the absence of global cognitive deficits. Academic deficits are frequently observed, which affect the child's educational function. And one of the reasons for this is arousal dysregulation, which is going to be the subject of this talk. This arousal dysregulation can affect a number of areas, including emotional development, and much of it has been linked to problems with executive function. Some of these problems can result in conduct disorders, which may be observed early or later on in development. However, we have also recently observed problems with health, including high blood pressure among children who applied for care and long-term effects on the health of adults. We know that damage to the central nervous system is the basis for the behavioral effects of fetal alcohol spectrum disorders. These include malformations and reductions in volume of gray and white matter in the brain. And when we evaluate the brain development, we often find thin or missing corpus callosum. The corpus callosum is the bundle of nerves that links the left and right hemispheres of the brain and allows efficient conduction of information across the two sides of the brain. We also see, as a result of some of these things, alteration in the activation of the brain, the electrical activation during the thinking process. And we see alterations in what's called functional connectivity, which is the efficient sending of messages from one part of the brain to the other. We do also sometimes see reduction overall brain volume. When we look at how these affect functioning, we can look at not only the way in which alcohol affects the brain, but also the outcomes in other kinds of disorders in which neurodevelopmental issues are the basis. We know that neurodevelopmental problems have effects on learning disorders and behavior. And this is certainly the case in FASD. We sometimes see impairments in ability, which may include delays in development or cognitive deficits. And these may lead to academic deficits, learning disorders, and underachievement academically. But we may also see behavioral deficits. And these can be manifest as attentional problems, what are called externalizing problems in behavior, which may be acting out behaviors, including impulsivity and sometimes aggressive behaviors. Sometimes we see self-injurious behaviors. When we look at the underlying factors associated with these problems, we often see impairments in arousal, or what we call regulation of arousal. When we're looking in terms of how this develops, there are a number of early signs of arousal dysregulation. And these may include greater stress reactivity, so greater reactivity, stressful situations, an inability to control early state. State is, I'll explain a little more later, but state is whether you're awake or asleep or attending or upset. We see problems in sleep regulation, and we see a greater incidence of negative affectivity, which means more upsetness, crying, irritability. As the child gets older, we see impairments in self-regulation in older children, and this can affect both emotional development and behavioral regulation, and it can have a long-term effect on cognition as well. Children who are affected in this way may have lability in mood, so they may switch from one state or mood to another very rapidly. They may show more irritability. They may show frequent behavioral outbursts. They, as a function of this, may have more difficulty learning new information because in order to be able to learn new things, you have to be able to control your state of arousal. Another thing that we frequently see in this group is what we call difficulty in shifting attention, and I'll say more about that. But this implies that they may become over-focused on one aspect of the environment or of the learning situation and have difficulty incorporating new information, allowing them to shift to other aspects of the situation. They may have difficulty sustaining their mental effort. One of the real bases for the ability to learn and function is the ability to maintain a focused attention on a particular aspect of the environment and to bring to that a sustained mental effort. Finally, there are frequently impairments in the inhibition of impulsive responding or in controlling one's impulses. When we try to understand this issue, we can look back at early development. Arousal regulation and self-regulation are highly related. And arousal regulation has to do with the way in which you control your reaction to external and internal stimulus. So if something happens in the environment, you may be overreactive. If you feel some internal arousal, you may not be able to control that effectively. Self-regulation involves learning to control arousal and behavior. And frequently we call this, as the child gets older, effortful control, which means that you exercise an effort in order to maintain self-regulation. And learning to do that is an important aspect of self-regulation, usually occurring in toddlerhood, 2 and 3 years of age. And that allows you then to exercise more effective interactions with the environment and to exercise self-regulation in situations where that's necessary. This ability is influenced by the individual's brain development and by the environmental input, so that if the child is growing up in an environment that is structured and organized and effective in supporting self-regulation, they may learn self-regulation more efficiently and earlier. If they are not, if the environment is not conducive to this, they may have more difficulty in developing this amount of self-regulation. And the other factor in this is the consequences, whether or not self-regulation is appropriately reinforced, or if they don't have self-regulation, if this is appropriately dealt with by the environment. So developing this is a complex interaction of these factors. When we think about this, and most efficient way of thinking about it is through what we call a developmental perspective. Self-regulation begins with the ability to control your attention to particular things in the environment. This attention is mediated by early development in the brain. And we know that individuals who are alcohol affected may orient or alert differently than those people who are not affected. So they may be over focused on a stimula, and they may have more difficulty in developing an efficient way to pay attention or orient toward the stimuli. As I said, effortful control comes on top of this and develops in the second year of life and is very highly influenced by environment. and involves the deliberate application of a cognitive control of arousal to allow most efficient learning. FASD and attentional regulation is sometimes impaired, and we have seen that early mediation or early regulation of this arousal and attention process is impaired sometimes. In addition, aspects of attention regulation can be impaired in middle childhood and adolescence. And it is also important to think of this in terms of ADHD, which is frequently diagnosed among people who are alcohol affected. But in fact, the pattern of impairment that we see in alcohol affected individuals is not exactly the same as we see in individuals who are diagnosed with ADHD. And therefore, we have to take slightly different actions to deal with it. When we think about how to address this, we're coming out of a background called optimal stimulation theory, which is sort of a lot of words. But what this talks about is that all of us have to be in a particular state of arousal to conduct the different activities of life. And there is a optimal or best level for different activities. So for instance, we want to be at a low level of stimulation when we're asleep. In order to be asleep, we want to lose the stimulation and reduce it as much as possible. And that is the lowest level of arousal. The best level of arousal for learning or interacting with our environment is what we call a calm alert state. And that is the state which we are trying to achieve most of the day in order to allow us to interact effectively with our environment. The excited alert level is the next one up, and that is when one is a little more aroused, and that may be appropriate for certain situations. If you're playing on a team or maybe giving a talk, you want to be at a more aroused level. Whereas another inefficient level for interacting with the world is the upset or over-aroused level, where you are physiologically over-aroused and you can't really interact efficiently. So one of the background features of what we're talking about is how to achieve for your child the optimal level of arousal. When we have a sensory overload, the individual tends to avoid other stimuli. So when you are over-aroused for whatever reason, either internal aspects or external, you become increasingly disorganized, your behavior is not efficient, you're not thinking straight, there's a tendency to withdraw or become hyper, your ability to pay attention shrinks, and there will be an increase in repetitive and inefficient behavior. When you are a person who is not getting enough arousal, you tend to be stimulus seeking, or you're going to go out and try to get more stimulation so that you'll become more aroused. So we believe that is what's going on with people who have ADHD, that they actually are seeking out more arousal in order to rev up the system to reach the level that's most efficient for them. And children become restless if asked to sit too long or display hyperactivity if they're too fatigued, for instance. And if we look at our graph, we see that when arousal is too low, activity increases, and when it's too high, they reduce activity. We can apply this approach to theory to various different disorders. And we believe, for instance, that in autism, people are too over-aroused, and they need to withdraw from situations in order to downshift this behavior. With ADHD, they're under-aroused, and therefore they try to rev up their activity. And that's why when we give them a drug that increases their dopamine levels, which makes their arousal more efficient, they react appropriately. Children who are cocaine exposed have heightened arousal responses, and they are over-aroused by stimulation in particular, so that we have to work with them to monitor their arousal level. With FASD, we see what we consider to be arousal dysfunction, which includes a slower gating of incoming stimulation, a reduced capacity to inhibit attending to distracting stimulation, and we have to often simplify the information we're giving them and allow fewer distractions in order to make their function most efficient. So how do we support self-regulation in children with FASD? Well, our goals in doing this are to achieve regulation of behavior, to move control from external control to internal control. And we do this by trying to develop what's called executive functioning skills. And to do that, we apply what's called a metacognitive paradigm to manage executive function and control behavior, which will allow the most efficient interaction with the environment. The long-term goal of this is self-regulation of a behavior. And we think of two different ways we can control behavior. One is extrinsic or external, and one is intrinsic or internal, which is self-regulation. Extrinsic involves rules, norms, other people's structure. Internal involves using the brain, the individual's self-regulation, to develop an organization that allows them to control their own behavior. And the way in which we do this is through metacognition or executive function. What is executive function? Executive function is a set of cognitive abilities that we believe regulates thinking, behavior, and emotional responses. These include memory, working memory, planning, judgment, inhibition, and the ability to switch attention effectively. These executive functions are supported by a certain part of the brain called the prefrontal cortex. And this is the last part of the brain to develop or myelinate. Myelinate is the way in which the brain makes a particular part of itself more efficient. And it involves something called myelin, which lines the nerves or the neurons of the brain. And as the brain is myelinated, those parts of the brain come online and those aspects of behavior or function become more efficient. Myelination develops over childhood and finally matures in early adulthood when the brain becomes, when executive functioning becomes most efficient. What is metacognition? Metacognition is a fancy word psychologists use to mean thinking about thinking. And it is considered a higher order executive, a higher order executive skill. It is important to self-regulation and control of arousal and behavior. And it typically is thought to include planning, planning to do something, monitoring what you're doing, and evaluating whether you did it the way you wanted to do it. So the question then becomes, how can we use this idea to work with children with neurodevelopmental disorders associated with FASD? We do this through something we call FAR. And FAR is a strategy that supports increased self-regulation and reflection. And it involves focus and plan, which is F, act, which is doing something, and reflecting, which is looking back and seeing whether we did it efficiently. And we use this strategy through a particular system that we call a couple of particular systems, both of which use these cards to help the child understand that they should focus and plan their activities, they should act, and they should think about what they've done. We use FAR for emotional and behavioral intervention through a particular program called GoFAR. And the idea of FAR was to reduce disruptive behavior with a particular set of strategies that involved activities for both the parent and the child. The general goal, and we did a study on this, which I'm going to describe, but we now use it more widely as well. The general goal of this study was to develop a novel and effective intervention for children with neurodevelopmental deficits associated with prenatal exposure. And we were targeting the affective and cognitive control deficits common in this population. And we did it through using a combination of a serious computer game and actual learning, experiential learning. Parents were involved in this, and they were given basic education regarding diagnosis, behavioral regulation, learning principles, and how to use FAR in working with their child. The general goals, as I said, was to develop ways in which we could work with the child to develop self-regulation. And we actually carried out a study using 3 different groups. One was a no treatment control group, and one was what we call the FASD treatment group, in which we had a different serious game. And finally, there was the GoFar treatment group, which included all the aspects of what we did. And as you can see, each group received a workshop on neurodevelopment and behavior. Both groups had a computer game, but one was called FASD, and one was our GoFar game. And both the GoFar and the FASD group did 5 sessions with the parent, which involved training sessions on how to regulate behavior. The behavior regulation training was based on our idea of an optimal stimulation. And we trained the parent to understand this issue and to work with their children on identifying when they were in the appropriate state. We taught both parents and children the FAR strategy. For the children in the GoFar group, we used a computer game of 5 sessions to teach the child FAR. And so the child was taught this metacognitive strategy of FAR using Miles the alien, who was our computer character, to work his way through a series of activities to unlock the door to get to the next level. The parents were also given basic education regarding their child's disability, and particularly how having alcohol exposure affected the ability to self-regulate. We taught them behavior regulation learning principles and how to use FAR in their home to teach their child basic life skills. The parent, there was a parent workshop initially, and then 5 one-hour sessions with behavioral counselor that covered social learning principles, modifying the child's level of arousal, and modifying the child's world to prevent problematic situations. And also there was a session on how to get your child to comply with behavioral instructions. We also developed a number of what we call BAT sessions. BAT were behavioral analog therapy sessions. And we developed all of these different sessions that we felt were things that regularly came up with parents that the parent and the child needed to work together on in the house. The parents selected those 5 sessions which they felt were most relevant for their lives. And they had a multi-step skill building workshop. There were a number of different activities involved. We also, if none of these applied, would develop individual sessions for the parents. The BAT session looked a little bit like these. These were 5 interactive sessions in which the parent, the child, and the therapist implemented the GoFar activities within the home. The goals for the therapy, as I said, were selected by the caregiver and tailored to the child's individual situation. And the child was taught to apply the FAR to daily living skills within the home setting. The BAT activity sheet might be getting up in the morning and eating breakfast, and the supplies are listed, the activity was described, and how this was implemented through the FAR technique is defined within each one of these sessions. So the child and the parent will focus and plan, the child will act, then the therapist, the child will reflect on the success of the plan. And then a plan for generalization is included, in which the parent can go home and work with the child. And I'm going to give you an example of how this works. So one of them might be clean your room. So typically when this is going on with a child with behavioral issues, the parent says, go clean your room, it's a mess. The child goes into the room and has a meltdown and loses control. The child goes to the room, stands in the doorway, is confused by the mess, ignores the instructions, which they've forgotten, begins playing with toys on the floor. The caregiver arrives and gets upset at the child not cleaning the room. The child gets upset. The caregiver may punish the child or pick up the room by herself. And as a result, the child is reinforced by not having to clean the room and by getting negative parental attention. And then it happens again the next time. When we apply the FAR technique, we develop self-regulation. The parent and the child learn the FAR rules. The parent and child go together to the room. The parent has a plan in mind. The parent asks the child to look at the room and develop a plan with them and identify the things that need to be cleaned up and to how we would implement FAR. The child then makes a plan. Once it's approved, the child acts on the plan. The parent and child review the results of this, and the child at that point receives positive reinforcement for appropriate behavior. As this behavior is learned, the parent can then fade their support out and quit having to go to the room with the child in the future. I recognize that sounds too easy, but it does in fact work when it is applied. And over time, this teaches the child methods for self-regulation, which can be used in different situations. This is our disruptive behavior form, which was identified, which we asked the parent to fill out daily and weekly. And what we found was that when we use these techniques, we did in fact see differences. Go far. These are the three different conditions. We had a pre-test before the child was given any interventions. We had a test after 5 sessions when the child and the parent learned the Go Far technique. We had a post-test after 10 sessions after the child had learned the technique and the BAT sessions had been implemented. We found that for the Go Far group, in which the child learned the game and the parent learned the technique, the behavior problems improved after 5 sessions. We found that in the FASDs group, after 10 sessions, when the behavior was implemented, the behavior improved after 10 sessions. And we found in the control group in which these interventions were not implemented, there was no improvement. And again, we also discovered that when we looked at a separate questionnaire, which looked at behavioral issues or adaptive behavior function in the home, that the Go Far group improved significantly. And the other group, the FASDs group, improved significantly. We also did what's called the TOVA, which is a measure of attention, and found that the Go Far group and the FASDs group both improved significantly, while the control group did not. So the conclusions from this were that the FAR technique, whether learned through the computer game in 5 sessions or through the BAT session in 10 sessions, led to a significant improvement in children's behavior. Those who did not learn the FAR control technique did not show better behavior over time. Therefore, children who have behavior problems due to brain-based problems and self-regulation can be taught self-regulation skills that will improve their adaptive function. We do believe that it's very important for the parents to be involved in these processes. Some one of the important aspects of this is that we need to make sure other people have access to these techniques. There is a GoFar online program on the Due to Learn website, which can be reached through the Due to Learn educational resources for special needs. You can click on that and then click on the GoFar link in this program and have access to all of the information about GoFar as well as the computer game. Another important question is this applicable in other settings? One of the issues that we frequently see in individuals who are alcohol affected is problems in school performance. And this is particularly evident often in math performance. And school completion may be negatively affected by issues with self-regulation as well. We have previously developed what's called MILE, Math Interactive Learning Experience, and this is a program to improve metacognition and behavior in young children that is applied to math skills. And there are a number of elements of this program as well. They include parent education, MILE instruction for children, training for instructions, and a train the trainer curriculum. This program aimed to improve mathematics achievement in young children and to improve effort for control of behavior in children from 3 to 10 years who had neurodevelopmental disorders. There is both a curriculum for this and a number of training aspects. And this program uses the metacognitive technique of FAR as well, both within the teaching session and overall. And it uses it overall in planning the teaching session and within the individual aspects of the teaching situation. There were a number of clinical trials of MILE, which are published and which can be identified in the literature. We've also had colleagues in Canada try this out within the school system, and they found it to be very effective as well. What we found from the MILE study were that parent education showed positive gains, both on those with neurodevelopmental deficits and on behavioral management. We found that individualized intervention plans were necessary, and these had to be focused on the child's individual needs. It was important also to integrate these things with the school and the family. The instruction, as we designed it, supported growth in areas that were specific to the individual needs of the child. And we found that it was most effective when it incorporated these FAR metacognitive strategies, which improved integration of information, and that we used frequent review and repetition. What does this mean for the individual child? Most of the children we work with can learn these metacognitive techniques to improve behavior regulation. Initially, it requires guidance from parents and professionals. However, we found that once children get it and learn the FAR techniques, it can provide them with a better way to approach day-to-day problems and activities. One of the amusing things we found was that many times, once the children have learned FAR, they will begin to apply it within a home. And we've actually had children, I remember one particular case in which the parent had ordered some furniture that came in a box and was quite baffled by it. And their child who had been working with us came in and said, well, you need to use FAR and focus and plan and act and reflect when you're trying to put this piece of furniture together. And the parents said, yes, that was true. And they did that and it worked. I've also talked to adults in other contexts, including a pilot who was a neighbor of mine, who said they use a very similar technique when they're trying to figure out what's wrong with their plane. So this is a particular technique that is applied quite widely to young children and to older children as well in a variety of situations. So this is what I had to talk about today, and I'll be happy to answer any questions. I know that you came in late, Amy, and if you have things that you'd like me to talk to you more about, I'll be happy to do so. You may also go on to our website if you are interested and get more information about our programs and about our center. And thank you for your attention.
All right, I'll stop the recording there. Thank you so much.